Good morning, dear Dr. Rosensweet.
Good morning, Carolyn.
It is nice to see you. Happy New Year.
Happy New Year to you and all the folks out there.
Yeah, well, there are a lot of us. That's for sure. I think we're having a Happy New Year. We're trying to have a Happy New Year, a day at a time. So here we are. It's been a long time. It's been far too long. I don't know. Just don't like that. A day without Dr. Rosensweet is not a good thing for me. I know, huh? So we have questions, and I was thinking this morning something that I had read a long time ago, and it's probably higher than this, but 6,000 women I've read per day are diagnosed as being postmenopausal, and so that means that there are a lot of new women per day to menopause, and we tend to, or I tend to, I should say, forget that like women are very, very new, and oftentimes we get questions that seem to be repetitive, and for me, I just don't mind that because I think that repetition breeds retention, and then the more empowered we can become, to help ourselves. And I know you've helped me with that a lot, and you've been very patient, and thank you for that. So I'm going to go ahead and start. I'm going to welcome Rod and our Facebook user, whoever you are. Welcome. Good morning, ladies. We'll get to your questions in a bit. So let me start with the first one. We have a very new member who says that she's been on birth control pills for 30 years. She stopped 8 months ago, and now she's taking Biased and progesterone. She states that she has debilitating anxiety, depression, serious insomnia, and is wondering if her receptors possibly could be dormant. And she wrote, like those of a 70-year-old, which made me kind of smile. And she's wondering if she needs to increase her estrogen doses. I get that question a lot. Higher, and if she should consider discussing with her doctor increasing this estrogen. And then the very last part, she says, what do you do for a woman who has low estrogen but cannot tolerate progesterone? Well, this is something you and I talk about often, this progesterone thing and the estrogen thing. Do you think that you can help us with that?
Well, let me break it out into her first question, which was, will the birth control pills be interfering, and are her receptor sites active, and should she increase her dose?
Yes.
And in a certain significant percentage of women who increase their dose, let's say of Biased or whatever estrogen she's on, I missed that one.
She is on Biased.
And she keeps on increasing it. A certain high percentage of women, if they slip into overdose, will feel it.
Mm-hmm.
They'll get overstimulation by the estrogen, and they will get breast tenderness, overstimulation of breast glandular tissue. They'll get breast tenderness. If they have uterus, they could even develop an endometrial lining and bleed. And some women even get agitated and emotionally uncomfortable from too much estrogen. Some women swell, but you can't rely on symptoms of overdose entirely. That's the thing. So you can't keep on increasing. The way that I could be able to better comment on the dosage that she's currently on would be to know what that dosage is.
Okay.
And also to know what her skin is like, because when you're applying Biased, how much it doesn't matter so much what the concentration of the Biased is. It matters how the absorption of the skin is. So there's a lot of moving parts, and this takes us back to the number one job that I see of every woman in menopause is to link up with a healthcare professional that really knows what they're doing here, because the numbers will be meaningful. And when in doubt, you can always do a 24-hour urine hormone test, no other test, just 24-hour urine hormone test. And there, as the Yiddish saying goes, der stinkt the gas.
There's
right?
yes. Another one.
Because do you know that? Do you know that one? Do you know that one, Carolyn?
Yeah. Wait,
Well, am I pronouncing it correctly?
I have to look it up, but it sounds pretty close. Yeah.
Because it's not so easy to go out there and find an expert, because unlike so many other branches of traditional medicine, there's no specialty.
But we're getting there, right?
And very few, well,
kind of, sort of.
But that's another question. we're making it happen.
Yes.
And so it's not so easy to go out into the world and find a healthcare provider who really understands menopause, understands dosages, understands testing. You know, so many of those who are prescribing, they've got broad-based practices, and menopause is a small part of it.
It can't
be. They don't become experts at it.
Yeah.
So yes, you can increase your estrogen to see if symptoms will alleviate. There's the symptoms that you listed can have different sources from just the estrogen. And what about the birth control pill?
That was going to be my next question.
Yeah. And
30 years.
The worst thing I've seen the birth control pill is not an illness. Just let's start there.
Okay.
And yet there may be things that it did that I'm not aware of. But, you know, the most significant thing that it will do is, like, when you start taking birth control pills 30 years ago, you're a woman who's getting maximum output of estrogen from her ovaries. And then you're adding additional estrogen because part of the birth control pill has estradiol in it. And so your body goes, whoa, we're already getting maximum output of estrogen, and now you're adding additional estrogen. This is too much. So your body has protection mechanisms to protect against what it's going to read as an excessive amount of circulating estrogen. And it does so by binding up. It produces binding proteins.
Right. This is where my mind goes, because it's so interesting, the binding. Go ahead.
Yeah, and so it increases its production of binding proteins, and it binds up, sort of mops up the excessive estrogen. Ovaries plus birth control pills, too much. Let's bind up the excessive amount.
Is that a protective device?
Yes, it is.
Yeah, in our body.
Our bodies really love homeostasis. They love to be in the zone, the optimal zone. And if you go out of the optimal zone, there's many regulatory mechanisms. And in the world of hormones, sex hormone binding globulin production, SHBG, can increase. And, you know, it's not an illness, like you were suggesting there. It's just a simple body protection mechanism. And so we address it, and there are ways to address it. But if you're a physician or nurse practitioner or healthcare provider wants to look into that, the thing to test is sex hormone binding globulin, otherwise known as SHBG.
Right.
So that should be checked, and if that's high, that can be giving you problems, and that's one of the problems that can result from birth control pill usage, and it doesn't have to be for 30 years. I've identified patients who took birth control pills for a couple months. The sex hormone binding globulin went up, and it stayed up. It didn't go down like it should. If you stop the birth control pills, the sex hormone binding globulin should go down.
I see the question that just came in, and I think it's appropriate to ask it right now. It says, so if the SHBG, sex hormone binding globulin, goes high, that means you have too much. And, you know.
It means you have too much hormone, or you may not have too much hormone. You could be a woman who's in menopause and has super low estrogen, testosterone, etc. But you took the birth control pill, it raised the sex hormone binding globulin when you were young, and it never came down, which is a bit of mystery. Because ordinarily, if you remove the birth control pill, the sex hormone binding globulin should revert to normal. But it doesn't always do that. And so mandatory in the menopause method, any menopause method member, patient that we have, right out of the gate, right in the beginning of our process, we send a woman to get a blood test for sex hormone binding globulin, as well as other things that we test for. But that's a mandatory part because there's been a lot of trouble from excessive sex hormone binding globulin.
Right. And so it kind of brings me back a little bit to what you were saying in terms of having a doctor who has a big medical practice and is like trying to deal with 50 different things. It's very hard to hone in just right on that one thing. Like, we need to test your, sex hormone binding globulin. We need to make sure you're this, you're that, you took the, I mean, it's in a 15-minute visit, it's almost impossible to do, you know?
Correct. And just to carry it a little farther, since the questioner didn't list the dosage she was on, there's an experiment she can do.
Okay.
Because here's the interesting thing. If she has a lot of symptoms, and we're hoping that those symptoms derive from insufficient hormones or incorrect hormones, we're hoping it does, well, there's an experiment that she can do. Because interestingly enough, if a woman's on too much hormones, too much biased, for example, she can still get symptoms of hot flashes, anxiety, etc. Too little or too much, the same thing will happen. It's not working properly. So there's an experiment she can do to see if she's on too much. If she stops all hormones and pays attention, if she starts feeling better from stopping, here's a quiz for our audience this morning. What does that tell us? So I'm going to pause here with Carolyn. Let's see what happens if someone, let's see what happens if someone gets the answer to the quiz. The quiz is, if you stop all hormones and you start feeling better, what does that tell us? Overdose? Were you on an overdose, or were you on too little?
It's an interesting question.
Interesting question.
It is.
No one's answering.
Nuh-uh.
We're out there, folks. Anyway, the answer is, well, Carolyn, you tell us the answer.
Well, I think, I quite honestly, I think it can be both.
No, if you're having lots of symptoms, oh, someone did answer. They said, read it, Carolyn.
Overdose.
They're correct.
And yeah, I agree. I stand.
If you're having a lot of symptoms that you think might be related to hormones, and you don't know if you're on a little bit too much, oh, they're all right. Here we go.
We got a lot of smart people.
5, 6 people have got it instantly.
Yep.
Yes, if you're on an overdose and you're still having symptoms of insufficiency, hot flashes, irritability, all kinds of stuff, and you stop, yes, you will feel better. Now, you won't feel better forever. After a day or 2 or 3, or the longest I've ever seen anyone go was 5 weeks. Oh my God, it took 5 weeks to get out of her body. But don't think in terms of that. If you're on an overdose and you stop, usually within a day or 2 or 3, you're feeling better, and then you're not feeling better. Then you're starting to get symptoms of insufficiency. Someone's saying, we are good students. Yes, you
are. Well, we have a good teacher.
So if you stop and you start feeling better, well, that won't last, because eventually you'll slip into insufficiency, and that's when you resume the hormones, and that's when you learn some information that you were on too much. Right. However, for taking the birth control pills for 30 years, there's an elephant in that room. We want to measure that sex hormone binding globulin. So, here we are. We're deep in the weeds as we've been before.
Yeah.
What does it speak to? It speaks to the complexity of what's going on, and it speaks to the need to deal with someone who's treating you to really be expert at what they're doing. And then what'll happen is you'll get it. Sooner or later, I promise you, no matter how raucous it is along the way, you're going to get it and you're going to go, oh my God, I figured it out. Now, then you get to cruise for 10, 20, 30, 40 years, knowing
That's a
how to.
nice amount of time to feel well.
So there's a response to that question. What's
You
the next?
know, yeah, I'm sorry. I don't get this cursor thing, and I had 3 good days, and that was it. We're good students. As happened to me, I stopped. I got better briefly. I hear that, I stopped my hormones, and I feel so much better. And then, bam, I get another, post saying, "Uh-oh, I'm not feeling so well. Now what do I do?" And I
Well, you resume the hormones, only at a
correct.
lower dose, and you don't go so high. And that's only one of the scenarios, though. Because I didn't have enough information there, I was just giving, some blanket stuff. It turns out that in any given individual woman, 99% of the time, there is a way.
Mm-hmm.
And sometimes in my practice, I take it day by day. We come up with an idea and we make an adjustment. And we see, how did it work out? Nice idea. Did it work? And we keep on adjusting until we get it into the lovely zone where a woman's going, oh my God, I feel good again. I feel myself. And then we do a 24-hour urine hormone test.
Right. Okay. That's gonna lead me right there into where is it? Where is it? Where is it? Okay. I'm gonna jump all the way down to my bottom because this hour goes so fast. You and I have talked of this before, but it continues to come up, and you just brought it up, and we talk about it all the time. And a woman asks about the 24-hour urine test. She's well aware about your feelings in regards to it, but she's wondering how it is that one can be taking hormones and feel wonderful, yet come to learn that her levels have shown way low enough to not be helping her bones, brain, vagina, etc. If she's been doing blood testing or other types of tests, is it possible for these tests to not give her the full picture? And conceivably, she's been feeling great, but these tests are telling her that they're not correct, let's just say, So am I making any sense? I
Oh,
mean,
yeah, absolutely.
okay, good. It's hard to write it out, but yeah, can we visit that a little bit?
Sure. To cut to the chase, I love testing. And I always have. And it doesn't matter what we're testing. No matter what we're testing, there's good testing and there's not good testing.
Right.
And when I entered the world of treating women in hormones 25 years ago, I started experimenting with the testing because the recommendations were don't test, it doesn't work. Those recommendations persist to this day in traditional medicine. The traditional medicine guidelines come from the American College of Gynecology, or they come from the North American Menopause Society. They're still recommending don't test. And you know what? They're right for the testing that they are cognizant of.
Right,
They're
exactly.
saying they're cognizant of saliva testing, and I have strong opinions. It doesn't mean I'm just going to give you my best shot. In my hands, saliva testing did not work. In fact, it was odd. And I have many, many colleagues in this field, and I'm positioned to know many, many colleagues, and they're almost of one voice. So salivary testing doesn't work. So you just can let go of that. And it doesn't work for ovarian hormones. And then there's blood testing. And for one thing, the optimal ranges for a menopausal woman have never been defined. So you're looking at a blood test and you're looking at laboratory reference ranges, and you have no idea what's right for a menopausal woman. Let me give you two bumpers. If you're too low on estrogen, you're at risk for losing your bones, osteopenia, osteoporosis, and you're at risk for losing your vaginal health, which is a big deal.
Mm-hmm.
That's not to mention your arteries, your brain. But if that number is too low, well, that number is not defined on blood testing. There's no laboratory report that you're going to get back that's going to tell you what that low number is. And if you're too high, well, that number is not defined on blood testing either. And what I consider to be too high is that you put your breast glandular cells into a state where they could do cell division, otherwise known as mitosis. You can put yourself at risk for breast glandular cell proliferation in your 50s. No, I don't buy it.
Right.
So that would be the optimal zone: too much and too little, bones and vagina at risk. Too much, breast glandular cells can proliferate. That's not defined in blood. But here's the biggest challenge with blood. You draw your blood. Yeah? Well, how long after your preceding dose? What if you took your bias in the morning? When are you going to get your blood test? 3 hours, 4 hours, 2 hours? Well, we don't know when you do your peak level. And blood tests go like this. You apply your bias. Oops, let's see, I'm backwards. And the blood level rises and then it falls. Well, when are you going to draw your blood? We don't know what your curve is. It's called pharmacokinetics. We don't know when you peak. I'm going backwards here. It's a real sort of I have to adjust my brain here. We don't know when you peak. Oops. I'm so sorry. I'm having a heck of a time getting this. Whoa. We don't know when you get high, when you have your highest level. We don't know when you fall off. When do we take your blood? Because it really matters. And it's dependent on when you took your last dose. So it's just so many problems. I agree with the North American Menopause Society and the American College of Gynecology. The blood tests don't work and salivary tests don't work, but they do not take into account the 24-hour urine hormone test, which does work. It's fantastic. Now, there's been new kids on the block by having a woman pee 5 times in a 24-hour and pee onto a filter paper. And this has got a lot of marketing play. And I want everyone in the audience to know I do not agree with this method. And there's science. When I first heard about it, I went, well, yeah, there's some scientific gaps there. Now, maybe I could be convinced otherwise. In fact, we have 2 people who are simultaneously testing 24-hour urine, blood, saliva, the 5-point urine. We're doing simultaneous tests, but I already know the answer because I've had so much contact with the laboratories. So to cut to the chase, 24-hour urine hormone testing just gives a practitioner, and thus a woman, every drop of information we could possibly want. And I'm here today because I've done 24-hour urine hormone tests for 20 years. Almost 25 years. So I'm not exactly remembering what the question was, but there's
no, I mean, you answered it because I think that the fear is that she's been doing blood testing. Yeah, you get it.
I remember. Yeah, there was this other part. And I did a test every year before I used to lecture at this major holistic conference. My partner and I were given a full day to teach doctors and nurse practitioners and pharmacists how to treat women in menopause. Every year before I used to go there, I used to ask myself, well, what have I learned in the last year? And one year, I decided to compare the 24-hour urine hormone test results on women who had, by clinical symptom alleviation, found their right dose. They say, for example, they started out with severe hot flashes and they woke up in the middle of the night with night sweats. We started them on a low dose and we gradually increased that dose. and their symptoms went away, and they went, "Oh my God, I feel better."
Ugh,
What
what a
we
relief.
do is we test 100% of those women, and my favorite time to test is when they say, "Oh my God, I think I've got it. I feel good."
Right.
Well, here's what we learned, much to my surprise. 50% of the women who said they felt good were on doses too low to protect their bones in their vagina, which is, you can bet that it's too low to protect the arteries in the brain, which
Oh
usually,
my God, it's scary to me. Yeah.
yeah. And 25% were on doses that were excessive, in my view, and put them at risk for breast glandular cell proliferation. That means 25% of the women who said they had got the right dose, "I feel good," were correct. They did. They were in the green, they were in the zone. They were in the optimal zone.
Well, that's good.
And 75% did not. They were not in the optimal zone. 50% of those were in the too low, and 25% were in too high. So the proper treatment of women in menopause include dose determination by symptom alleviation,
right.
plus testing by the 24-hour urine hormone test.
Right. 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 Right.
You can feel good. This is to answer your question. You can feel great, and you can be on too much or too little.
Right. Right. That it's scary to me. I don't like to use the word scary either, but I am, because for me, Carolyn Shapiro, I don't want to be walking around feeling great, but having the hormones not doing any good, so that I'm going to end up with adult diapers, in 2 years. Thank you very much. Or you can, come and visit me in an assisted living.
Fun, not fun.
Not fun. And yeah. Okay. So I hope that answered the question. 24-hour urine testing. I do the 24-hour urine testing. I like it. I feel safe with it for sure. We've got some good questions coming up. I want to get to, this is a very, I think for you, an easy question. I want to respect it. What does titrating to symptom alleviation mean exactly?
Well, many, many women, not all, but 75% of the women who start losing their ovarian hormones, they get raucous symptoms. Small, medium, large, or humongous. Life disruptive. Like, some women wake up in the middle of the night with a night sweat, and they can't get back to sleep because their mind is racing. That is a symptom of estrogen insufficiency. Some women are getting 10 hot flashes a day. That is a symptom primarily of estrogen insufficiency. So when a woman like that comes to a provider, we first learn about the woman, and then we start them on a low dose of estrogen, for example. And because we don't really know their dose, they're an individual woman. They have individual absorption needs, sensitivities, all kinds of variables in there. But we start every woman on a specified low dose of an estrogen called Biest, for example. And we gradually increase that dose over the course of a month. And best case scenario, she starts feeling better. Oh, that's cool. And then she starts feeling good, because as she's gradually increasing the dose, her body's getting back into the realm of appropriate estrogen levels.
And so is that called titration?
That's the technical name. Starting low and gradually increasing until you hit a specified endpoint is called titration. It's a chemistry term.
Mm-hmm.
It's a really good one.
Mm-hmm.
That's what it is. And we can do the same with progesterone. For example, a woman who's gone into perimenopause or menopause and starting getting more anxiety than she ever had, will start with a low dose of progesterone, gradually increase that dose, and if her anxiety goes away, my goodness, she has had symptom alleviation by dose titration.
Yes.
Same with testosterone.
I've been through all three of them. I get it. I get it. And it's a good word. And you can titrate up and you can titrate down.
Correct.
Okay.
Yes, if you titrate up too high, you could wind up going right through the good zone.
Yeah.
And go into the too much zone, and you could get symptoms of too much estrogen. You could get overstimulation of breast glandular tissue, and then get breast fullness, too much fullness, and breast pain.
You know, I got to do this, and I'm sorry I do, but there is this book right here. It's called Happy Healthy Hormones. You can download it. And I got this book going on 3 years, Dr. Rosensweet. How wild is that, right? And in this book, along with also, you know, your method in the oils that I take, comes in this book. There are pages that explain this, you know, like the symptoms of too much estrogen, the symptoms of too little estrogen, the symptoms of too much progesterone, too little progesterone. Same with testosterone. And you look at it and you're like, oh my God, this possibly could be me. It's really cool. You know, I've never been to a doctor who ever gave me something that said, here, you might want to like study this out a little bit. Not even close. I did. Yeah, we'll get into that story one day if you want to do some therapy. So anyway, yeah.
Tell people how to download that, Sharon, Carolyn, because we can do that for no. They can download it for free.
On the ins and outs of menopause with Dr. Rosensweet, I'm going to pin it to the top of the page. Anybody who wants to download this book can do so, and they can do so free. And it comes out, and you put it in a binder, and you're going to learn about menopause. And it's a really fun book, too. And there's a lot of Yiddish in it. Right?
Yes, some, yeah.
You got the ish in there.
Yeah.
So anyway, yeah, good book. And I will pin it to the top. I would love for women to get this book because it really explains out menopause, and it explains it out very well. But we got the real deal here right now, so let's use that. I think that we kind of got pretty much to my questions. Oh, one more. And talking about your book, in chapter 9 of your book, and I just turned to this page the other day. It was really weird. Page 96, you discuss in great detail why we should stop hormones for like 2 to 3, maybe even 4 days per month. And one of the members is wondering, A, why do we stop hormones? We've discussed this, yes. And B, what happens if we do not stop these hormones for these days each month? Is that dangerous?
Excellent question. Picture this. These ovarian hormones, biest, testosterone, progesterone, DHEA, they're fat soluble. And what that means is when you apply those hormones to your skin and they get into your body, they circulate around your body, and one of the places they go is to the receptor sites in every cell in the body that has receptor sites, and they do their thing. They do their estrogen thing, they do their progesterone thing. Another place they go is to fat. They dissolve in fat. So they go to our fat cells, and they can build up. So for example, we need vitamin A and vitamin D. Oh God, we need these. These are so crucial to us. And we need the right amount. And these two vitamins, as well as vitamin K, are fat soluble. Unlike B vitamins, they're water soluble. If you take too much B vitamins, you're just going to pee them out. And you're going to have
vitamin C too, right?
Vitamin C, yeah, absolutely.
But not the other.
Water soluble. You're just, if you take too much vitamin C, it's never going to hurt you. You're just going to pee it out.
Right.
But not so about the fat soluble vitamins. Not so about, let's say, vitamin D or vitamin A. You take too much vitamin A and it's going to build up in your fat tissue, and you're going to get an overdose in your body of vitamin A because it's going to store there. In fact, there's many people who loved carrot juice.
Ugh.
which is loaded in vitamin A, that wound up getting yellow palms because vitamin A is yellow. And as it builds up in your body, you can turn yellow.
You look like a big carrot.
Exactly. And the same is true of fat-soluble vitamins.
Or hormones.
Take too much biased, it's going to build up in your fat tissue. And your levels are going to get too high. So one of the ways that we prevent this is this way. For one thing, we're titrating to optimal dose. Then we're testing. And when we see that test result, I can tell a woman when she's in an optimal range. You're in the optimal range, whatever hormone we're talking about. But just to add to the possibility, let's say that it showed up on the chemical testing and the hormonal testing that she was in a slight overdose. I'm sorry, let's say it showed up in the testing that she was in the nice range. But let's say that the dose that she was taking was actually 20 molecules more than what she needed in any given day.
Okay.
Over time, she's going to build up in her fat tissues. Hello. She's going to build up in her fat tissues.
Hello.
An excess of estrogen over time. It's going to build up there. She won't notice it. She was only doing 10 extra molecules a day. I'm just using an example.
Right.
You're not going to unlikely to notice that.
Right.
Well, one way that we can prevent that from happening besides the testing is if we stop once a month. So let's say a woman is taking Biased every single day and she stops on the first of the month and sees what happens. Let's say on the first day of stoppage, she feels fine.
Mm-hmm.
Let's say on the second day of stoppage, she gets a hot flash.
Mm-hmm.
That's how much strategic reserve she had. She had enough to last her one extra day. And what we know if she got the hot flash is once a month, we got her into a safe zone to protect from any kind of excessive buildup. Well, we only do that experiment once. Once a woman says, I'm at a good amount of estrogen, then we have them stop once a month and we have them determine how long does it take before you get a symptom. If a woman stops once a month and the first morning that she's omitted her hormones, she gets a hot flash, what we've learned about her is she was on the low end.
Got it.
Dosage. Let's say she stopped once a month and she doesn't get a symptom for 2 weeks. Oh my goodness. And then at the 2-week mark, she got a symptom of a hot flash. That woman was on an overdose. She wasn't even taking her hormones, and yet she had enough hormones in her body to prevent hot flashes.
Right.
So it's just one of the multitude of good things we can do to fine-tune this so you're not on an overdose.
Right. But operative word being multitude.
Yes, there's a lot of ways to approach menopause that a woman, bottom line, can wind up with an excellent program, a safe program, and one that can last her a lifetime.
Oh my
God. What about that?
Yeah. No, it's amazing. It's amazing. And it's important. And again, I think the more that we learn, the less we fear and the more empowered we become. And this, many ways to approach menopause. We want to feel well. And you're a man. God bless you. You haven't gone through menopause.
Yes, I have.
Well, it would be andropause.
Well, thank you. You're so correct.
So you taught me a thing or two. We men and women too. Men, what we like you say in your book, we like our hormones, and when we don't have them, we feel it and we know it, and we don't like how we feel without them. So there's a question that was presented that has now gone away from me, and
I'm gonna bring it back, Carolyn.
Is it about the estriol, that one?
Well, which one do you want? Tell me what I'm doing here.
It's the one where they talk about the difference between estrogen and estriol. I think it's about 4 down from what I'm seeing. Do you see it?
I'm looking.
Yeah.
I saw that one that had estriol in it.
Yeah, it said estriol. I mean, it's the only one that says estriol. See, because I think that there's a confusion with women when it comes to estriol, and they think that they're supposed to just take estriol, period, without the estradiol.
And that has been done.
Mm-hmm.
And there's the question.
Thank you for finding it. I apologize that I just cannot.
There's the question.
There you go. Can estradiol be too stimulating for someone and they have to switch to estriol? That's an interesting question to me.
So the ovary actually puts out 3 major estrogens, not just one. The strongest of the estrogens that the ovary puts out is called estradiol. And it puts out a second hormone called estrone, which is about as 80% as strong as estradiol, or the biochemistry is so interrelated that we could just call it one other step in a biochemical pathway. And it puts out a third estrogen called estriol. And estriol is about an 1/8 as potent.
Right.
Estradiol. However, it's more prevalent. In fact, if you were to add up the amount of estradiol and estrone, you should have at least as much estriol as you've got the sum of those two.
Right.
In fact, studies have been done. I did a study on it. I got 1.1 times the amount of estriol as the sum of estrone and estradiol. Another study that's famous in the holistic literature, in the hormone literature, there was 1.3 times as much estriol as there was the sum of estrone and estradiol. And estriol is very, very important. It's that when you test a young woman, that's what you see. She's got more estriol than she's got the sum of estrone and estradiol. And when someone's got more of something than they got the others, you start asking yourself the question, why is that there?
Yeah.
There might be a reason.
Right.
And there is a reason. And I don't know that I'm going to dive into that, but quite yet.
All right.
Can estradiol be too stimulating for someone is Elaine's question, and they have to switch to estriol. I never look at it like that.
Yeah, I haven't either.
Now, there was a time in history, and I don't know if it's still going on, when estriol, treating women in menopause, was very popular as the only hormone they were given in Japan and in Europe. Never happened like that in the United States. There's good reasons for that. Estriol is protective to a woman's breast. There's good reasons for that. Well, that's not how the body does it. And I continually like to copy nature.
Yes.
And not try and invent a new woman by giving her hormones different than are what natural to her. And it turns out that when we do a urine test on women, we can tell by measuring the estradiol, the estrone, the estriol, is she following the pattern that nature did? That's our goal. And what I find universally is, in order to get the nature pattern, you have to prescribe a combination of both estriol and estradiol.
And that would be called bias.
Exactly. And how much the percentage is, well, we always start 100% of the women on a formulation that has 80% estriol and 20% estradiol. And about 70% of the time, that's going to produce ultimately in that woman a pattern of testing that replicates what she was when she was younger. Sometimes we have to make it 70-30, sometimes 60-40. Sometimes we have to change that ratio. No one should be changing that ratio. No one should be changing that ratio unless they're looking at a 24-hour urine hormone test. No one should be changing that ratio.
I cannot tell you how much I agree that no one should be changing that ratio.
Unless they're looking at a 24-hour urine hormone test that gives them the evidence that to copy nature, they're going to need to change that ratio.
Yes.
And so so that's the real, if estradiol is too stimulating, it's often because the dose is not right.
Right.
And estradiol is stimulating, and you need the whole picture. You need sufficient progesterone to balance the stimulating effect of estrogen. You need, in my book, the proper amount of estradiol so that the estrogen receptor site beta, going down into the weeds right now, so that the estrogen receptor site beta gets proper stimulation, the deproliferating. So you can tell it's a deep topic. And to answer your question, Elaine, can estradiol be too stimulating for someone? The dose is not correct, or it's not getting balanced. If it's too stimulating for you, the dose is not correct, or there's not enough progesterone, or your body's saying something's not right. So what do you do? When the body's saying something's not right, I just try and move the body towards copying nature.
So I often tease, the plant world and its brilliance and amazingness, is very happy to share with us. And I'm running around my place here. There's a lot of foliage, and I'm always thanking the plants. I'm like, thank you, because they do have what it is that we need. And I think that estriol tends to get a bad rap in menopause land.
Estriol gets a bad rap.
Estriol does get a bad rap. It does.
Oh, that's incorrect. How do you know?
I'm not saying that
Test billions of young women and tell them that the estriol that prevails is the most prevalent estrogen they have is bad.
Yeah, right.
That's what you'd have to do.
Yes, I know. And it's an argument that's very difficult to argue for me. I don't think you'd have a hard time because you're the doctor. But
I do see that there is a question up there that's pretty interesting.
Okay.
It says, my doc has only estriol and testosterone. Well, that's not a bad idea. And there is some benefit there. I would never, what it tells me is your doctor has done some studying, and they realize, and maybe they've gone so far as to understand that estriol stimulates estrogen receptor site beta, which is the deproliferating of breast glandular tissue. So it's protective in that way to the breast. So instead of getting proliferation in a 50-year-old woman, every 20-year-old woman, to be normal and healthy, needs once a month breast glandular cell proliferation. Oddly enough, or amazingly enough, every single month, a woman prepares for the possibility of pregnancy, including breastfeeding right there in every cycle. So every woman's breasts who get normal hormonal output get fuller during the cycle. And it's because one of the reasons they're getting fuller is there's extra breast glandular cells being produced every single cycle in preparation for a possible implantation in pregnancy, and thus ultimately breastfeeding.
Right.
And once a month, if she does not get pregnant, all those additional cells that were formed, all of them disappear by a planned obsolescence called planned disappearance called apoptosis. And estriol stimulates the receptor site that does that. And we don't want to be putting a 50-year-old woman through cell division, mitosis. That's when those cells are most vulnerable for some kind of DNA change there, otherwise known as a mutation. So estriol, there's a lot of benefit to it. And I could see that a doctor would read about the estrogen receptor site beta and deproliferation and think, hey, this could be protective. I want to do this safely. However, you're going to see that you can't do that with hundreds and hundreds of women. They're just not going to respond well. They need that estradiol. Women are going to need it. A lot of them, majority of them, are going to need some estradiol because why? Because that's how our body's designed. So we don't give too much. And the final thing I'd like to say is, let's say that this is the range of estrogen possibilities in all young women. Some women are going to be at the low end of this range and feel perfect and be perfectly healthy. Some women are going to be at the high end of this range. All of them are going to be menstruating and healthy. Talking about estrogen. Well, how much does a menopausal woman need? Not this much. If she gets this much, she could get breast glandular cell proliferation because that's what happens to young women. Here's how much a menopausal woman needs. This much.
Right.
Right below what a young woman needs. It's just fabulous to study this stuff and realize that the menopausal woman can get all the goodies that she needs. 95%, that's a wild guess, of menopausal women can get everything that they need: protection of the brain and the bones and the arteries and thinking and libido and the vagina and the bladder, from less than what a young woman gets. Now, there's always exceptions. And there's a certain percentage of women, they need more robust levels of estrogen.
Yes, as we discussed. And
there's women who have cognitive decline that they just need the estrogen blast. And so that's such an important thing that, I'm fine if a woman's losing her cognition and we can't get it with those lower menopausal doses. We'll increase the estrogen until we get it. And she gets
yes.
And that's women who have done this. And so, it's a big field. There's a lot of moving parts. That's the good news. We know so much about it. The bad news is to do this right, you have to find and link up with a healthcare provider who's excellent.
So you do that doctor shopping. You do that doctor shopping.
What, my dear, I have a hard stop in 2
minutes.
minutes.
I know, and we have all these questions. So I'm gonna go ahead.
Answer one short one, but I have to complete it 5 minutes to the hour.
No, it's fine. It's totally fine. I want to say thank you. It's good to see you again. We're getting back on track, and that's really cool. And welcome all the women in, and we will get to these questions. There's so much. So please get this book. I'm telling you, Happy Healthy Hormones. It's going to explain a lot to you.
Here's one I want to answer.
Okay.
Hi, does female testosterone have any side effects, please? Well, in any hormone that we can name, you need them all. And you really need them. As a matter of fact, you really, 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 really need them. And you definitely don't need too much. These hormones are so powerful that there isn't a hormone that you can name that if you take an excessive amount, you're at risk for trouble. So the issue is just get the right amount. And you don't need too little. And if you're in menopause, your testosterone is dropping. And there isn't a single woman I've ever tested that somewhere along the line, early in menopause, her testosterone level is low. And you need testosterone. You need it for your muscles. You need it for your bones. You need it for your well-being. You need it for your mood. Oh, God, you need it. So the whole deal with any single hormone that we can name is get the dosage right and know what that right dosage is. And that's one of the beauties of the 24-hour urine hormone test. We test a woman while she's taking her hormones. And we get a real-time view of, well, does she have too much testosterone? Well, that's not good. You're going to get side effects. So you're not going to get the side effects from testosterone if you have got the right dosage. And you
balance.
will get side effects from testosterone if you got too much testosterone.
Yeah.
And you're going to have long-term things that you do not want to have. I promise you, this testosterone is as important as any hormone that you're going to ever get in menopause. Testosterone is right up there. They're all important, but you definitely want that testosterone. Why do women go into assisted living and nursing homes? A certain majority of them go in because they lose their muscles. They start with canes, then walkers, then wheelchairs. And when they hit the wheelchairs, if the family can afford it, they go into assisted living facilities. And then they're not holding up their bladder, so they get incontinence, so they get adult diapers. This is about testosterone. You want to get testosterone right. I'm going to sign off.
So we're going to have to say goodbye.
Yes. Until next time, Carolyn. What a pleasure to see you again.
Ladies, talk to you later, Dr. R. Thank you. We'll talk to you on Tuesday. Have a great weekend.
All right, you too. Hi to
See you later, everybody.
Bye, everybody.